Radiologists. My name is Dr. Jennifer Nathan, and I'm co-moderating this evening's event with Dr. Bob Pyatt as we are co-chairs for the ACR RLI Power Hour webinar series. Before we get started, there's just a few logistic items we did want to go through with you so that you can better participate in this evening's event. So when you join this evening, you join through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel, and we have an image of it here, this black box. There's two icons on this black box, the Zoom control panel, that we do want to draw your attention to. The first one is the chat icon, which I'm circling here with my cursor. The chat icon is what you would use if you're having any sorts of technical difficulties. If you're having an issue, click on the chat icon, up will come the chat window, type in your concern or your question, hit send, and then our support staff will see it on their end, and they will be reaching out to you to help you resolve this issue. The second item, or the second icon I want to mention on this bar, is the Q&A icon. This you would use if you want to ask any of our speakers a question. So how you ask a question is you click on the Q&A icon, up comes the Q&A window, you type in your question, hit send, and then we will see your question on our end and we'll ask your question for you. As a side note, you can submit questions throughout the entire webinar. However, we will only be collecting them and addressing them and asking them for you when we get to the Q&A session at the very end. One other item we do want to let you know about is that this is a recorded webinar, and that also includes the Q&A session with the participant questions. So we just want to make you aware of that. So I'm now going to turn things over to Dr. Bob Pyatt to introduce this evening's faculty. Dr. Pyatt?
Great, thank you, Jen. And it's quite a pleasure to have three outstanding faculty in this evening's program. Our first speaker tonight will be Andy K Moriarty. Andy completed his residency at Henry Ford Hospital and also a fellowship he completed in abdominal imaging and cross-sectional intervention at UCLA. At Advanced Radiology Services in Grand Rapids, he is a member of the board of directors, the vice president of clinical operations, and he also serves as chair of the quality committee. Andy is an assistant professor at Michigan State University College of Human Medicine, where he serves as director of quality and safety. He is the current YPS representative on the ACR Board of Chancellors. Our second speaker tonight is Dr. William Donovan, MD, MPH, FACR. Dr. Donovan has spent his career in private practice in Connecticut since finishing his neuroradiology fellowship. His group used to be in a small group averaging 8 to 10 FTEs for many years, and his practice joined with a larger regional group in Connecticut 2 years ago, this resulting in a group which now numbers greater than 30 radiologists. Dr. Donovan has been active in economics affairs for the ASNR as well as the ACR, and he currently serves as chair of the ASNR Health Policy Committee. He also serves as an ASNR counselor to the ACR and has been an alternate member of the RUC panel for radiology for over 10 years. Our third speaker tonight, Dr. Mark Mullins, MD, PhD, FACR, is a professor and vice chair for education in the Department of Radiology and Imaging Services at Emory University and Emory Healthcare. Dr. Mullins is a former core radiology clerkship director, as well as the former diagnostic radiology residency program director, and he is the current director of radiology medical student education. Regarding ACR service, Dr. Mullins is a former Committee on Strategic Planning and Compliance chair. He is also a Subcommittee on Education Program Evaluation chair. He's served that as well. And he also has been on the Measurement and Assessment Subcommittee co-chairing that, and he is the current American Institute of Radiologic Pathology Advisory Committee chair. In 2017, Dr. Mark Mullins became a fellow of the ACR. It's quite a pleasure to have these three tremendous faculty tonight, and I turn the program over now to Dr. Moriarty. Andy?
Thanks, Dr. Pyatt, appreciate it. I'm going to take over Jen's screen here. All right, well, thanks everyone for joining. I'm Andy Moriarty. I'm a private practice radiologist here at Advanced Radiology Services in Grand Rapids. I have no disclosures, and tonight's topic is recruiting radiologists. So I want to start by giving you a little bit of data about a fellowship survey that we had performed from graduates in the pre-COVID times. We asked about 4,600 recent ACR graduates about their experience as first-time job hunters or immediately after graduation. We sent out the survey to people who had recently graduated from the ACR membership and training category. This includes their last known contact email address and usually provided during residency or fellowship. We had about a 10% response rate, and you can see that almost half of them were within 1 year of graduating and getting into their job, with a smattering in the first up to 5 years. The distribution of fellowships weighed heavily on abdominal, interventional, and neuroradiology. We compared this distribution to the ACR Human Resources Commission annual workforce survey to make sure that our sample was sort of representative of what we see when practices report their patterns. One of the discrepancies we saw is almost no one reported doing a general radiology fellowship, while a significant number of radiologists still practice in a general environment. I would say that we all know that beginning in the 80s and 90s, there was a increased interest in fellowship for radiologists, and that was really about 50%. That number had grown to around 90% by an APDR survey in 2008, and a more recent survey of the Chief Resident Association, the A3CR squared, indicates that almost all residency trainees and graduates now practice at least one fellowship. I do want to be a little reassuring, and their survey also found that 80% of graduates really do just perform one fellowship, and the remaining 10 to 20% are split almost equally among people who do 2 fellowships in different specialties, 2 years in the same fellowship, 2 fellowships on the alternate pathway toward extras training, and then 3% of the group who really just do no fellowship and go straight into practices. The next question we asked was, well, what kind of practice would you prefer to go on the top line, and what practice did you end up accepting? And you can see from the survey that about half of the survey participants wanted to go into private practice, around a quarter, almost a third, wanted to go into academics, and then a small percentage indicating a preference for government or teleradiology employment. And those are pretty close to what actually happened. We asked the graduates, well, what was most helpful in securing your job? And by far and away, it was residency and fellowship contacts, followed by a national or subspecialty board. And then further down the list, 1% or so for Googling or looking at groups. Interesting, cold calling there was around 20%. People just looked at an area that they wanted to be in or practice, and they called and said, can I talk to someone who's recruiting or hiring? We compared this to a Merritt Hawkins survey of also radiology graduates. And what did they say the number one thing was? Well, they said that it was personal networking for 67% and residency contacts or job boards for 34 and 24% respectively. On the right hand of the screen, we asked our survey participants, well, what's the most important thing for you when you're looking for a job? By far and away, group culture, number 1, 2, and 3. But if we had to rank them after that, it became location, followed by work-life balance, and then daily practice, what I'm doing in my day-to-day work, what sort of specialty mix I get for a subspecialization or general radiology, and finally coming in at 5th and last in our survey ranking was salary. So the question we always ask is, well, if I want to live in a particular area, does it really matter where I do training? Should I go to the best institution, or should I just practice solely in the area that I want to end up practicing for the rest of my career? What we find is the ranking of our survey participants here shows where they did residency, fellowship, where they preferred to end up practicing, and then where they actually ended up practicing. And being from Michigan, I'll point out that we have a large number of training programs. We rank number 3 there in the residency training, and kind of high up there on the fellowship. Surprisingly, not a lot of people put as ranked up high in the preference. And I find it interesting that California was the preferred preference for almost a quarter of our survey participants, but the 10% actually ended up practicing in Texas. So I hope everyone's doing well in Texas right now. And if any of you have been able to join us, that's very great. The next question we asked was, where did you want to end up practicing in comparison to your subspecialty? And then here we compared this to some survey data from the AAMC that looks at all specialties. You can see that the national average is about 50% of people end up practicing in the state where they train. Radiology is a little bit below average here, but I think this is weighted more by the large numbers of people who are in internal medicine, pediatrics, and family medicine who are in the above average part of that category. The interesting thing is when we broke it down by radiologists, you can see that your subspecialty almost matters more. If you're going to train in a very subspecialized area like neurointerventional radiology, you have a low chance of ending up in practice in the place that you trained. Now that just might be because of the subspecialty training and needs that are in that area. You might have to move to where there's a job available rather than being able to take a job that is in your geographic area. And we also noticed that men tended to move just a little bit more than women. We're not sure if that was a significant in our sample size or not. And then finally, we asked them, what about underserved areas? You can see the national average is 24%. Radiology is pretty close to that. We seem to be following the national average and not really changing as much as everyone else. Of course, all this data was obtained before 2020, and then we all know what happened with COVID. And so I'm going to hand it over to Dr. Bill Donovan to talk a little bit about some of the changes that we've seen on the ACR job board since then.
Thanks a lot, Andy. This is some information again from the ACR Jobs Board and the Radiology Leadership Institute. And it's, again, we have more information from pre-COVID than we have from the past year of the pandemic that we've been suffering through, but it still gives us a little bit of background, of course. What happened after COVID hit, to cut to the chase, I think we all realized that employers were reluctant to hire because they didn't have a good sense of what their income was going to be and what their business was going to be and how long COVID was going to be with us for and how long it was going to affect everyone's business. So as has happened many times over the years in radiology job market, but more abruptly perhaps and more severely this year, there's a cycle, and the cycle said that people weren't willing to hire. And the last item under employers, though, is important: private practice, mergers and sales. There's been such conglomeration of practices over the years, and there's been such conglomeration in healthcare facilities in general that everyone is still thinking in private practice, how do we see ourselves in 5 years? Do we have to remodel? Do we have to rethink our organization? Do we have to sell ourselves? Do we have to join up with somebody else? That hasn't stopped since COVID hit. In fact, it might have impelled some groups to think harder. But that does tend to put on pause active job hiring if a group is in the midst of negotiations to potentially merge with another group. Job seekers, of course, were left stranded when COVID hit because of the fewer number of employers seeking employees and because of the disruptions with travel and the initial reluctance, I think, of people to get into the Zoom interview milieu. We'll do the next one, Andy. So as you might expect, employers looking on the job boards at CVs of potential candidates was going up, and then it went down, and then it went up. But then when March of 2020 hit, it crashed pretty significantly because everyone put their potential hiring on hold, or many did. Next. At the same time, perhaps candidates looking for jobs maybe saw that there wasn't a lot going on. And of course, this is partly cyclical based on the academic year and the fellowship year. Fewer people are looking for jobs in spring because they may have already found a job or they may have already taken a new fellowship position. But of course, this is compounded by COVID. When it was March and April of 2020, people may have been sort of huddling together, marshaling their resources, deciding what to do next. And then, of course, once the academic year turned over, people started looking for jobs again more actively, and that coincided with the first phase of, theoretically, the first phase of reopening after the initial COVID wave. Andy? Top states actively recruiting, recapitulating what Andy showed earlier, pretty much the most populous states. There's been some shifts, some come, some go. Andy, next slide. And then again, recapitulating what Andy said, you've got about 2/3 to 3/4 of jobs in private practice and significantly fewer in academics and in hospital-based employee models. Next. So in 2019, the job postings went up and up and up. And I can attest in our group that it seemed like business was booming and we were on an upswing, and we would definitely have been interested in hiring people. And we were interested in hiring people. And then there was a bit of a slowdown as winter came, and also as maybe fellows and residents started accepting jobs from July to October. So the numbers went down a little bit toward the end of 2019. Next. And then job postings in 2020, as you can imagine, kind of tanked in the spring, slowly went up a bit, but it's not really a trend that I think anybody can count on. And we don't have numbers really yet, obviously, for 2021. I'd call that a plateau or a holding steady as opposed to a significant rise and subsequent fall. Andy? So what does 2021 bring? Well, we'll get to that, I think, later on, especially with Q&A. Right now, I'm going to introduce Mark Mullins to take over and talk a little bit about academics. Mark.
Thank you. So I'm just going to address a few topics right now, and then thank you to everybody who submitted questions beforehand, because it gave us some topics and some questions for us to address. I want to start out by saying I don't have any conflicts of interest that are relevant to this discussion today. And then also, I was just going to say I'm only speaking for myself. So just to let you know. All right, a few points that I wanted to make in general, and then I'll sort of talk a little bit about, sort of the last couple of years from my vantage point. First of all, my experience with the COVID era with recruitment, initially, my experience sort of paralleled the data that's been shown here. So things seemed to tighten up. So for example, our fellows, some of them were told that they were going to have a time period when, for a delay for starting their jobs. Not all of them, some of them were, not all of them. And then, of course, interviewing for jobs for the people who didn't have jobs was challenging. But as you know, there's been a pivot to do interviews electronically. And that has been, I think, in my purview, really, really successful. It's been a really nice thing. So the kind of format that we're using today is very familiar to us at this point. I'm sure you feel like this is very familiar to you. Whereas a couple of years ago, this would be special and different for some of us. And there are lots of benefits that come from that, obviously, right? So time, effort, energy, money, there's a lot of potential benefits. So in terms of that pivot, that was pretty efficient. In fact, some of our training programs were still interviewing when we went into quarantine mode. And it was quite effective even early on. So it was sort of a lull, and I think everybody was just sort of waiting and trying to see what was going to happen. Just the fear of the unknown. As Bill was talking about, I've seen it a couple of times over the course of my short career. And then in terms of moving through, like several months into it, things seem to open up a little bit more and open up a little bit more. So in terms of that peak, let's not call it a peak. In terms of the upswing that Bill was showing you on that graph, I could feel it in terms of talking to our residents and fellows. And I sort of pay attention to our trainees, figure out sort of the ebb and flow of it, because it gives me an idea about the ground level view of what the job market looks like. And within a few months, things seem to be much better in terms of that, because people were getting busy again, and I'm sure they felt like they needed the help. In terms of how we recruit nowadays, just, sort of segue into that, we are doing virtual interviews. And I would say that not only for first visit, but in some cases for second visit. One of the questions that was posed prior to the webinar was, is anyone doing on-site interviews? I've heard of some, and I've heard of some advanced sort of, maybe third visit, final visit, that kind of stuff going on. I've also heard of people taking jobs or offering jobs without any on-site interviews. So it is quite a new world that we live in terms of this. So that is certainly something that's occurring. In terms of how we practice, when I was looking at the stats and thinking about teleradiology, I would dare say many of us live in a world now that has blended teleradiology with academic radiology. For example, I'm on my home workstation right now. I never had a home workstation until COVID hit. So I would say this is a very common situation for people. And some of my colleagues work predominantly from home. And of course, we've pivoted in academia, at least in our place, to be able to do a lot of the work remotely in terms of supervising residents and fellows and teaching and whatnot. I will say that early on, it was very important for me to have a physical presence in the hospital system, because I did not want our trainees to feel like they were being left out and not supported. I did not want them to feel like that they were sort of out by themselves. And I thought that was very important. And so whenever I had the opportunity on clinical practice, I made sure that I was physically there. But I certainly understand there are plenty of colleagues that I have that have other things going on, young children or what have you. And it's interesting how close it's gotten in terms of how we practice. So it's very interesting to me in that regard. People talk about retention and switching jobs and things of that nature. Academia, private practice, academia, private practice, academia. I think unhappiness in this era is multifactorial. So it's really hard to sort of pin things down. And, logically, that's going to affect job satisfaction, recruitment, retention, all of those kind of things. Thematically, when I looked at the questions that were submitted prior to this, a few of the things that I kind of want to point out is one size does not fit all. So some of the questions would center around the idea of like optimizing recruitment or optimizing your ability to get a particular job or what have you. I would say that, you really can't be all things to all people. And one of the questions circled around the idea that people don't want to do nights, people don't want to do weekends. That's not been my experience. I would agree that it's not most people, but I've had several trainees that have taken night jobs specifically for one reason or another. And over the course of time, like for example, when I was a trainee, wasn't that long ago in the scheme of things. I graduated residency in 2002. So like in that era, it was very uncommon for people to want to work nights per se. But I've in the, flash forward 15 years, 20 years, whatever, it's like I've had several trainees that have chosen those jobs in particular. What's the game changer? Well, I noticed that a lot of them took jobs where they work a week and get 2 weeks off. So that I think has been a game changer. And so that leads me to kind of point out that there probably are ways to incentivize certain types of jobs that, would make people look at them and think they're more attractive. So, you know, um, I don't really want to work nights, but on the other hand, there probably is an incentive package that would get me to think about working nights. So, you know, I mean, I'm sure that there are ways to kind of incentivize people to do those things as far as that goes. And so I will say, you know, I'll address a few other things about, you know, academia from my vantage point here. I think we're a lot more alike these days than different in terms of what we're, you know, the environments we're working in. I work in a big academic place with several different hospitals, and I'm, you know, for the big private practices, I'm sure that's very similar. Working with a whole lot of different people, and, you know, I do practice one subspecialty, you know, but, you know, a lot of the people that I train end up practicing one subspecialty, if not the majority, if not all the time, the majority of the time, and close to all the time. So, you know, I think we're a lot more alike these days than different. And I think that it's good that we can kind of understand each other as far as that goes. One of the topics that we were asked to cover today is the idea about, you know, someone who's subspecialty trained working outside of their subspecialty versus someone who's general trained. And I'm sure it's going to be covered from other vantage points, but I will say from my vantage point in academia, we generally focus on people with a fellowship, subspecialty trained, but we do have plenty of people that work outside of that subspecialty on occasion, if not some good percentage of the time. Why is that? Well, sometimes we have people split time between two or more divisions for one reason or another. Sometimes people have gravitated towards emergency radiology, and then sometimes people join what we have in our group. We have a community radiology group, which is a multidisciplinary group. And so I'm sure there are other places out there that are very similar in that regard. So again, you know, I think we're in a lot of ways more alike than different these days in terms of that stuff. I will say that there's no magic way to sort out who's going to be a great resident, who's going to be a great fellow, who's going to be a great hire for your practice. But I will share with you what I do when I talk to my mentees about this is I say, you know, you've got to figure out your value system, and then you've got to figure out the place's value system. And then you've got to figure out on the Venn diagram, are there two circles, which it's only a matter of time until that falls apart? Or is it close to one circle? I don't think I've ever encountered a situation where there's exactly one circle, you know, the two completely overlap, but there should be, you know, hopefully a lot of overlap in terms of the value system. And the questions that I encourage people to ask when they go, when they sort of talking to places is, when people do well here, what is that like? What are they doing? And when people do poorly here, what is that like? What are they doing? And then, you know, open-ended, be quiet and hear what they have to say. And I think that's usually very telling. And so, you know, the example I usually like to give is if they're like, okay, people here never eat and they never take vacation, they never use the bathroom, and we pay them a whole lot of money. And that sounds great to you, fine, you know, but if that does not sound great to you, then, you know, it's probably just a matter of time till it falls apart. So I think that sort of is my version of looking at like what the culture is. And I agree with that, you know, the number one line that Andy showed earlier about, you know, like looking at that and saying group culture is super important. I absolutely positively agree. So I just wanted to hit a few topics. I'm more than happy to address some other of the questions in the Q&A session. And if there's something that you want me to talk about in terms of academia from that side, I'm more than happy to address that as well. I'm trying to keep track of the chat and the Q&A. So I'm glad to do that. Again, thank you for inviting me. So I'll pause here, and I think we're going to go on to Q&A.
Okay, well, thank you to our excellent speakers this evening, Drs. Moriarty, Donovan, and Mullins, for your insight and expertise on this challenging topic of recruitment. We're now going to move on to the Q&A session. So just as a reminder to everyone, to ask a question, you go to the Zoom control panel at the bottom of your screen, click on the Q&A icon, up pops the window, you type your question and hit send, and then we'll see your question on our end. So we do have a question here, and I think Dr. Mullins actually addressed a little bit of this. So this is for the whole panel. In your recruiting experience, what is the current trend for employment and experience in recruiting a pure subspecialist versus a subspecialist who is capable or interested in reading outside of their specialty versus hiring a non-fellowship trained general radiologist? Is there a recruitment difference in academics, private practice, or other types of national groups?
Well, that's a long question. I can
Yes.
try and jump into that. And it's going to touch on what Mark said. I'll start by resonating with what Mark said, which is that if you think about the academic medical centers out there, they've been buying community hospitals for some time now, and frequently they've been taking the radiology group that has been working at the community hospital under their wing and making them in some way part of their organization, and yet allowing them to continue working in that fashion. And at the other end of the spectrum, a lot of private practices have been either merging with other private practices or seeking out partnerships with large multi-specialty clinic organizations or academic medical centers. And so you've got, as Mark said, a blend where now you may go into a job interview thinking you're interviewing for an academic interventional radiology job and find out, well, you can also work at the community hospital where you'll do some IR, but you'll also be expected to read CAT scan and maybe some MRI and do as well as light interventions on days you're not doing IR. And if you want, and on the other hand, if you go to a private practice, you may find out, well, actually, if you trained in neuro, we're going to have you reading neuro 80% of the time because that's what the neurologists want. That's what the neurosurgeons need. And every third patient in the ER is getting a stroke protocol CTA, and we don't want people reading those who aren't reading them a lot. So again, it's blurring between academics and private practice. And when you go to interview at a place, I mean, that's an entirely appropriate question to ask. Where are your new hires working and what sort of milieu are they working in? I mean, presumably they're going to tell you that sort of thing anyway, but perhaps armed with this information, you're not going to be quite so surprised if you find out that you're in a blended environment, more or less. I might have lost track of part B, C, and D of the question, Jen.
Can I add something to that? So I'm going to piggyback on that. I think I totally agree with that. And a useful question is, you know, when I'm interviewing candidates, I'll say, if you had complete control over your time here, like you join us, you have complete control over your time, what would that look like? What would you be doing? What would you like to be doing? You get some insight into what people, you know, find to be useful. And then the flip side, that question's useful if you're interviewing. Just say, you know, if you hire me, what do you want me to be doing? What do you need from me? Maybe it's bare minimas all day, every day, you know, maybe it, you know, and just knowing that helps, right? So, you know, okay, good. I know what I'm in for, you know? And so like Bill said, some of my trainees over the course of time have joined groups and ended up doing things, at least for some period of time, that they didn't anticipate they were going to do because it just didn't come up. And so the other thing is I've had trainees that sort of get, you know, they get hired for particular subspecialties, just like Bill was talking about, whether it's obvious or not. And so my trainees who train in breast imaging, for example, very commonly when they take a job, that's the expectation. So like in asking that question, like, what do you want from me? You know, what do you want me to be doing? Then at least you know what you're getting yourself into. Interventional and breast imaging are the ones that I find are, if not 100%, asymptotically approaching 100% of what they want them to do. And then the other ones, it's a lot of the time sort of a balance, you know, neuro being a close second in terms of that.
Yeah, and I'll add, of course, the small population of pediatric radiologist subspecialists will frequently do mostly pediatric radiology. I wanted to say one more thing. I'm sure Andy has something to add as well, but along the lines of what are private groups looking for in candidates, which is a question that's been asked since the beginning of time. I think the answer is still diversity, the ability to do virtually anything. No one, I think, really confidently expects, in other words, hirers don't really expect you to be able to do 100% of all radiology across the board. That's unreasonable, but 80% or 75% would be good. And it's not usually a good look for you to go into an interview saying, I can do everything except breast. I'm not going to do breast or something like that. I mean, you want to be enthusiastic when you're looking for a job. You want to highlight your strengths and emphasize those, but don't bring up what you might perceive as your weaknesses or your dislikes. The ability for a scheduler to be able to put you, a candidate, into any of their milieus, inpatient, outpatient, hospital setting, and be able to fill the seat competently is still, I think, paramount in private practice. And of course, when you're looking for a job, then you do want to be able to highlight that special something. Of course, your subspecialty training would be one thing. But if you can get across anything else, interest in the job, business side of the practice, an ability to discuss the politics of how the health organization that you're hoping to join is succeeding, or what their track record is, or what their plans are for the near future, that will show an interest in things beyond the moment-to-moment workday to your interviewer that can be helpful. I'll pass it over to Andy. I'm sure he has some insights too.
Yeah, thank you. I wanted to build on that question and also go back to Mark's topic about, what would your ideal job look like? I always tell people when you're starting out, especially coming out of training, you're almost the most de-differentiated you will be. And one of the important things early in your career, unless you absolutely know that you want to be the left adrenal gland specialist because it's a completely different drainage pattern than the right side, is to not close doors to your future self and your future practice. Keep your options open as long as you can. And it's okay to dabble for a little while and to figure out what you want to do. Dr. Donovan mentioned pediatrics. Even in a group of like mine, 170 radiologists, it's difficult to recruit pediatric subspecialty radiologists. So I think that's a more of a trend in their fellowship training process and a national shortage. The question about recruiting for pure subspecialist or capable of reading outside their subspecialty, I always think that flexibility is the key, right? The ability to sit in multiple seats is very helpful to a group, no matter the size. And, would you want to have someone who's non-fellowship trained as a general radiologist? I think that goes on to Bill's point about, we always tell our recruits, well, what's your plus one, right? We expect that you are going to be a competent radiologist. And, if you did a neuro fellowship, you're going to be excellent in neuroimaging. But what's the one thing that's outside of that, expected clinical practice that you're going to bring to the group? Is that expertise in health policy or an interesting quality? Is it being on the peer review committee or practice building? What one extra thing are you going to do for the group that differentiates you from the other candidate who also has top-notch training and is expected to be a great radiologist when they come to us?
Yeah, I'll jump back in by agreeing exactly. I was going to say some of those things as well, Andy. And along with the plus one is not only maybe do you have a subspecialty fellowship, and not only are you willing to do, quote, everything, unquote, but if you can also bring something of a more recent vintage, like are you going to be helpful reading prostate MRIs, or talking to the group about dual energy CT, or starting or enhancing the coronary CTA program, those are all, and the point being, stay interested in your residency. Don't cut anything out. Try and keep track of everything. Unfortunately, an impossible job, of course. But again, if you can get some extra special experience in an extra special niche, that'll be very attractive, even if you're looking for a general radiology job with a private practice.
Other comments?
Can I pivot to a different topic?
Sure.
Yes.
Okay. So I'm going to bend together a couple of the questions and some of the trainee topics for just a moment, if
Okay.
we can. So first of all, some people were asking about, what trainers are looking for. Hopefully you got from me that it's not one size fits all. And so I believe what you should do is be yourself, be your best self, but be yourself. Figure out what your selling points are and what your group culture is, and then try to figure out ways to let people know, what that is. And so, which leads me organically to a few of the other topics that are here. So people are wondering when to approach trainees about jobs. I can tell you that people are recruiting our residents currently. So that is going on actively. That is a thing. We are back to that point. For those of you who know your last few decades of history, it's gone back and forth, a little later, a little earlier, a little later, a little earlier. There are probably positives and negatives to each version of it. But, it probably, I would be very, very uncomfortable recruiting someone before third year of residency because, hard sort of knowing about de-differentiated to another level. And you worry that someone's going to change their mind at that point, right? I mean, it's 2 years, 3 years down the line, it's very difficult. However, as we all know, if you wait too long, then of course you've lost some of the candidates, right? So there's that part of it. For my trainees, I talk to them about the idea of deciding on a job early might be helpful in terms of figuring out what the group wants from them, right? So for example, if you want me to be able to read prostate MRI, or you want me to be able to be the left adrenal gland expert, like I've got time to add that to my arsenal, so those are things that theoretically could be done. But yes, people are recruiting residents is definitely a thing. However, some people just sort of hold their cards, right? And so they wait till fellowship and see what that's about. So positives and negatives and stuff like that. So I do want to give a shout out to Nolan's point about behavioral interviews, which leads me organically to talking about diversity. It is not lost on me that the three of us, Jennifer is the moderator, so the three of us on the panel may not appear very diverse, and it's not lost on me, and I get that. And I just want you all to know, I believe very, very strongly in diversity. And so it's come up a few times in the questions. One of the questions was, do you feel like diversity should be something on people's websites? I think you should be able to get a really good feel for who a place, what a place is from the websites. That's a common way we try to figure things out. When I talk to my mentees about looking at websites, I'm like, this is a way for people to show what they think is important. And so you look at the pictures they show, look at the things they brag about, look at the things that they talk about, look at the opportunities that they mention, like how do they present themselves? This gives you a lot of insight into it. And it may not be perfect because, maybe the person putting together the website, maybe they hired a company, maybe it's completely peripheral, maybe, I don't know, but it gives you some insight into the kind of programs they have and who they are. So in my experience, I think this is, like nowadays, it may be a little more evident on the academic side. You may see it a little bit more. But for me, I think it's very important because the diversity part brings diversity of thought and diversity of experience, which I think is a great thing. So when I'm doing recruitment, I'm very cognizant of it. I believe in it very strongly. And so one of the questions was, is it better to have homegrown trainees and hire them, or is it better to get people from the outside? I mean, both can be good, but I will tell you that one of the great benefits of having a mixture of people, some that you've trained and a bunch of people from elsewhere as well, and from all over, is that they bring in different ways of thinking about things. So for example, when Bill was talking about stroke imaging, if you only are hiring people that you've trained, they're probably going to have you're going to have an echo chamber of ideas, and no one's going to be able to come in and like say your place isn't doing dual energy CT as you were talking about, and maybe, you hire somebody from another place that is doing dual energy CT, and they can come and they can bring that part and they can talk to you about these other things, but also how they think about things differently. And so having people from all over, I'm lucky to work in a division where we have people from all over. We have some people we've hired from internal, but from all over. And I think it brings a lot of diversity, and I think it's very positive. And so on the flip side, I wouldn't avoid hiring people that you've trained just because you've trained them, right? I mean, sometimes, they're fantastic and they want to stay, and, like that, you're just like, okay, that seems like, a good idea to me, so I wouldn't sort of shut either one off, but in general, I think a mixture of the two is a good way to go. And that brings a form of diversity as it comes through.
Okay, great. We have a question here. A current look at the ACR Career Center shows a third of the jobs posted are from PE-backed corporate practices. Do any of the panelists believe these should be classified as different than a private practice? How do you see these practices impacting the job market as competition for a traditional private practice?
I'll start there and we'll kind of pass it off. This seems like this is a number of questions actually that are going to be answered in live fashion. And, being in a physician-owned private practice myself, I think it's important for candidates to be completely aware and go into eyes open. I think there was actually an article just published over in Current Problems in Diagnostics, something I will find the link and share it, where it's incumbent upon the person interviewing for the job to know exactly what kind of job they're interviewing for, right? So you are looking at a practice and you have to decide if that's a culture you want to join. Now, there's trade-offs in private practice and academics, in groups that have outside funding, and you have to ask yourself if it's worth what you want in your professional happiness and practice, and what's actually going to work for you. And then, the flip side of that is you have to get the practice to give you, the most accurate information that you can at the time of. And there's a couple of questions about, will you have a geographic restriction? Well, potentially, there may only be one type of practice setting that is available in the area you want to go to. And that could be, if you're looking in Kalispell, Montana, there's only one kind of practice there. But if you're looking in an area that is dominated by academics, then that might be it too. So it's very local and regional dependent. And I would encourage people to just kind of be informed when you go to look for jobs of what kind of practice you're actually interviewing in, and what kind of career and profession you want to have in your practice.
I'll try and say something about corporate radiology. The easy thing to say is that it's impossible to predict what situation we're all going to be in 5 years from now, at least speaking from the private practice perspective. I know you might remember in the bio, I was a member of a relatively small group. We varied from 7 to 8 to 10 people over the course of 15, 20 years, and had perfectly steady business with 5% increase every year. And then we thought that we were a little parochial, and we saw the possibility of losing market share because we were basically getting surrounded by larger groups and healthcare facilities joining together with each other. So we merged with a larger group. Now we're in a larger group. We have good market share in our areas, but we did basically interview or dance around with a corporate entity and with a different larger regional group in our area. And of course, the problem with the corporate entities is you will have no control in what the future of that situation is, unless you're one of the very top people in the group that they might actually seek the advice of or the counsel of. But they're going to be presumably dollar driven for the most part. I mean, they want to see long-term success, so they're not usually going to alienate all of their employees, i.e. their doctors. At least they're going to try not to, but it's very difficult to predict what the best situation is going to be for you. And even if you join a group that seems great, what's going to happen with that group 5 years from now? So I want to wrap this whole item up by saying that, yes, ask the group, ask the people that you're interviewing with, What is your structure? What is your business structure? Are the partners are all partners equal? Are some partners specialer than others? And in addition to things like years to partnership and what's the track record been along those lines, what you're really trying to get from the people that are interviewing you is a sense of comfort and a sense of openness and a sense of transparency. And you have to really rely strongly on your gut feeling when you come out of an interview. You're going to get some data points. You're going to have some information. You're going to know where it is. You're going to know basic things about job hours and salary and things like that. But there's going to be a lot of unknowns, and it's going to be a shot in the dark and a leap of faith. And you've got to feel good about the people that are potentially hiring you, at least on a person-to-person level. If you get an uncomfortable feeling from either the main interviewer or the other members of the group that you may interview with, you've got to pay attention to that. And even if everything else seems perfect about the job, that's got to weigh pretty strongly in your decision.
Any other comments? Okay, our next question for our group, we really look for partners to have a willingness and ability to do areas outside of their fellowship, as well as a willingness to do nights and weekends. How common is it for private practices to ask for this, and how do applicants feel about this?
Well, alluding to what I said before, I'm sure Andy has some insight into this too. We would want to see diversity. We would want to see flexibility. We would want to see people who want to work late shifts and weekends. It's pretty much a prerequisite to becoming a partner in a group to, go all in and do what's needed to be done, and not to walk in and say, if you want to structure your lifestyle to work only nights or no nights, no weekends, no late shifts, things like that, you need to be ready to expect to not be on a partnership track and to be some sort of limited employee. And, that's the way it's been for many years. And I don't see that that's changed much. If you're not going to be there, and be able to be counted on all the time and get the random phone calls in the middle of the night, then you aren't going to be considered to be a major investor in the future of the organization. So I think that still goes on, despite all of the modifications that are being made across the board in all sorts of practices.
Yeah, and I would say that is very similar to how our group does it as well. I think that if you look at some of the answers that we've been typing into the chat box there in the Q&A and try to get to everyone's question that we can, is a lot of this is very specific, not only to your individual situation, but very specific to the practice needs. And that's one of the things that you'll have to answer, not only your own personal preferences, but also you'll have to feel out the group, and you'll have to feel what they need and how much you can ask for, and what you can really negotiate with, if anything. There are some people who have been able to negotiate no nights, no weekends as a partnership track, but typically those people are who bring extra value to the group in one facet or another, doing something that improves the group's culture, standing, as part of practice building. If you just come and tell me that you want to work 8 to 5 and go home and not participate in any of the group leadership activities, that's probably a different track. I don't know, Mark, any thoughts about that?
Yeah, I like the idea of trying to sort out, who is all in and who's not. I think that's a great point. And then also I like the idea of figuring out ways to negotiate added value. So for about 3 years, I did full call and was program director. And my hair didn't used to be this color, and I used to have more of it. I could stand 3 years of it, but about 3 years in, I said, I just can't do this anymore. Something's got to go. So I ended up doing less call at that point. They took mercy on me and I did less call. So, but, I think that, at least for the 3 years, they could see me as all in, and know that, there's that part of it. But sometimes people talk about, they'll say people negotiate this and negotiate that like it's a bad thing. I don't think it's a bad thing, right? I mean, just like I don't think negotiation is a bad thing. Culturally, it's just not something most of us do, right? We're not trained in it. It's culturally kind of a different thing. And so I think it can be very useful. So like I said, we've got to be ourselves. You know, the candidates need to be themselves and the places need to be themselves and be our best selves and then kind of sort it out.
Any other comments? Okay, our next question. Do you have an idea as to whether graduating residents or fellows are looking to work in a full-time capacity, like 4 to 5 days a week, or more in a part-time role, 2 to 3 days a week?
I can start on this one. The people I've been training have almost universally taken full-time positions. And if for no other reason, the vast majority of them have huge loans to pay off, and they commonly bring this up. You know, they don't have the choice really in a lot of situations. That's just, you know, it is what it is, you know? So I will say that's my experience.
Any other comments?
I think it's very variable. Again, it depends on the situation. We've had some people who, you know, the vast majority of the people want to be radiologists who want to be full-time, it seems like. And I think that that's a good idea, unless you have very unique circumstances when you're coming out of training, because you really need those formative years to build speed, to accuracy, to follow up on your cases. And it's hard to do that in lower volume settings. You're just not seeing enough cases. It's the reason that radiology residency is 4 or 5 years is you need to reach that 10,000 hour rule just to, not in the concept of becoming an expert, but 10,000 hours is the baseline to prepare you to excel to be an expert. And so once you've reached that threshold, you really have a chance to develop your professional acumen. And then once you're a couple of years out, you can do that. But we have had some people who come in and have specific circumstances and they say, I want to start off at half-time or 3/4 time and potentially going back up in the future, but it's very individual specific. I'm on the tail end of the millennial generation. So I think that my group definitely was interested in full-time as we're coming out of training here, and we'll see what happens with the next generation.
Any other comments? Okay, our next question. Do you guys offer partnership to evening and night radiologists?
Andy's larger group could probably answer that better. We are not in that position yet. We are looking for a second shift person, but we have not taken the plunge into looking for strictly night or weekend people. Andy?
Yeah, we're very diverse. We have second shift and third shift, what we call alternate tracks, and we actually just did some market research. One of the really easy things is to go to the ACR job board, and you can actually search the Emergency Society job board as well, and those tend to have a number of jobs, and you will see that there are partnership tracks jobs out there of varying lengths, subspecialty requirements, as well as hours and days off, and they range. There's week on, week off, there's week on, 2 weeks off, and the market is kind of in flux right now, but there are a number of jobs out there that are partnership track for evening and alternate track only work.
I will say, and I'll just mention for academia, people who work predominantly nights, weekends, holidays, that kind of thing, where they're predominantly doing it, it's more challenging in terms of getting some of the academic work done around regular meetings. So of course, like the weeks that they're doing that, they can't have meetings, or can't go to things, that kind of thing. So, but in the era where they're getting a week or 2 weeks off, then theoretically they might be able to make up for it that way, which is different from the typical academic experience where you don't have a regular loss of weeks at a time where you can't have those meetings. And so it can be challenging. The people who are working predominantly nights, weekends, and holidays in academia, I think, like in my experience, our people, they still get to work with a lot of trainees, so they have that part of it in the academic experience. But in terms of the other parts of it, scholarship and collaborative research and things like that, it depends.
Any other comments? I see Andy's responding to this question, but I'll also open it up to everyone. How often do private practices offer education subsidy as a recruiting incentive?
Yeah, I just responded that I think it's very
Yep.
individual. There's some practices that might offer it, but there's practices who won't, and it's, depends on the people. Some people have large loans, and we've seen from the AAMC data that some people, a third of graduates come out with no loans, and they don't see a subsidy as an interesting part of their recruiting package at all because they don't have loans to pay off.
I instantly assumed that the question related to going forward, do practices reimburse or pay for CME opportunities for their hires? And that's pretty standard still in my book. It's done different ways depending on the corporate structure. If you're a private practice only with only physicians in the group, then you can be more flexible than if you are a corporate entity that also has technologists or administrators and lower salaried people. That affects the benefits package that you can offer, and one of those ways is it may not be quite as generous as far as offering reimbursement to travel to meetings and that sort of thing.
Oh yeah, I saw it as a recruiting incentive, but yeah, if it's just the daily package, I think most practices do offer some sort of CME. Every practice wants you to stay current and bring new things to the practice.
Okay, I think we have time for one last question. The question is, how important is CME budget for recruitment?
Depends on the individual. Is it important to you? I might have some people who say, give me a bigger paycheck. I don't care about, having money to buy a subspecialty membership or to go take a trip to Chicago for RSNA in the fall or in the wintertime. But some people, It's a deal breaker, right?
COVID's also shown us you can get some amazing CME without leaving the, comfort of your own home. It's amazing.
Yeah, that's for sure. Again, it's that might be a negotiable item that you can talk to in the midst of the hiring process.
I would say thematically, this touches on something which has always irked me, is the idea of, I believe we need more transparency on both sides in terms of jobs. So for example, I always sort of encountered these ideas of taboo questions about like asking about how much salary, because certain jobs in certain situations might be a non-starter if the salary range is not at a certain level for me to take a particular job. And so you can't ask that question out front. And if that information is not readily available on the website or what have you, it's a challenge, so like these kind of topics that we're talking about, like, the reimbursements or CME, what have you, is it negotiable? Like what's negotiable, what's not? Like, would I have to do all neuro or no neuro, or work all Fridays or no Fridays, or what, like all this kind of stuff. Like what's, in a perfect world, you'd have an idea so that at least, you're in the same ballpark, like you have an idea about that. That would be great. But I don't think we're going to get there anytime soon. Some places are more transparent than others, and I think that's great. But I would encourage everybody to consider it, because I think that's that's always something that's annoyed me. It's like, there are these questions which are extremely relevant, but you can't ask them till the second interview, third interview, something like that.
It's important to you, ask right away.
I think that it's evolving too, and especially again in the era of Zoom, you're entitled to some factual information, and I think people are less embarrassed about asking, and I think interviewers are less put off by some direct questions. It's got to be some sort of a balance. You don't want to go in there as an interviewee, guns blazing, and tell me this fact, that fact, and tell me all the bad blood in your group. I was typing a response to one of the questions about how do you find out about group culture. Usually people are not open with problems in the group. It's the same sort of concept in that how open do they feel? How open do they make you feel, and how comfortable do they make you feel about their willingness to talk about these things? They're not going to tell you something the first day that you're interviewing. about something that happened 5 years ago and that could be potentially embarrassing to a former colleague of theirs who may still be a friend. But things happen. These are human dynamic interactions we're all having. And if they're express some comfort level with talking to you frankly about the fact that, well, this person left 4 years ago for this reason, this person left for a personal reason, but we've had excellent retention otherwise. And, you know, if you come on board, we're happy to share these things with you. It gets to the point of, you know, what's the culture? How open are they? And how willing are they to talk about the facts as well, that Mark was talking about, the salary and the bare bones.
Okay, so we're just a little bit over the hour, and we do want to be respectful of everyone's time this evening. So first off, I want to thank our speakers for their insight on this complex topic. And I want to thank you to our participants for also being here for this webinar and asking some really great questions. So I'm now going to turn things over to Dr. Pyatt to conclude the webinar.
Thank you, Jen, and we really appreciate the superb program tonight with Drs. Moriarty, Donovan, and Mullins. Thank you, gentlemen, for all your help tonight and great questions and answers. Please share your feedback with us. We will be sending everyone a post-webinar survey and a recording of tonight's program next week. Please feel free to share that with your colleagues. They may also find it very valuable. Coming up next in the RLI, the next program is on branding strategies and how to define and redefine your personal brand. This program will be on Wednesday, April 21 at 7 p.m. Eastern. You can register for this program in April or any other free RLI Power Hour webinar at www.acr.org/Power Hour. Again, thank you everyone for attending tonight, and we especially appreciate the work of our faculty. Thank you, gentlemen. Have a fine evening.
Thank you, everyone. Good night.
Good night.
Thank you.